All right, we're recording. So welcome everybody back to another PCBH Corner. I'm really excited about this one to have Neftali Serrano on. This is actually the second PCBH Corner that we've done with Neftali. The first one is like the PCBH Corner that was lost forever, and it really, my mind beats me up so bad about it because it was a great PCBH Corner. Like I remember leaving that, I think it was in Charlotte that we did it. And I remember we were in like the ballroom of it, and I think there was some noise and stuff, but it was so fantastic. So I hope we can replicate that today. Neftali, do you want to introduce yourself? I'm imagining most people that are watching the PCBH Corner know who you are, but do you want to just kind of introduce yourself, talk about your current role? We're going to get into, obviously, what brought you into integrated care. But yeah, if you want to give a little introduction.
Sure. Yeah. First, thanks for having me on. I hope to duplicate whatever fantastic thing you remember. That I remember doing it. I don't remember anything of what I said. But yeah, I'm grateful to be here with you. Grateful for the work that you do. First of all, I want to express thanks for what you and Bridget do at your clinic. It's a beacon of light and hope for our health system. And for the PCBH model in particular. So we're looking at you. We're looking at you as our future. So thank you. Thank you for the work you do. I am for those of you that don't know, I'm the CEO of an organization called the Collaborative Family Healthcare Association. And our mission is to promote integrated care by supporting our healthcare professionals who have that heart really to bring behavioral health and medicine together across the entire health system, but particularly in primary care, which is sort of the heart and soul, we think, of the health system. So yeah, most of my day is talking with great people like David, helping clinics get their programs up and running, putting content together for education to educate healthcare professionals across the country. Yeah, just generally trying to make sure that we continue to revamp the healthcare system in a way that makes more sense. So yeah, perfect. I'm happy to be here.
Perfect. The one question that I know was just completely inspiring last time, and it usually is, and I feel very fortunate that we get to do these PCBH corners and learn from the people like you, the pioneers that have really driven this, and ask that specific question of like, what got you started? Like, what was the draw? Why do integrated care? Why work in primary care? Do you want to speak on that a little bit about what was the draw for you to work in primary care?
Yeah, I'll try to give you the abridged version because there's a huge mix of personal and professional that are part of that story. It starts with me nearly quitting being a psychologist right out of grad school. So I had gone to 5 years of postgraduate education, gotten my doctorate, was actually on a road trip back home from Illinois to New York. I grew up in New York City. And with my wife, driving through upstate New York, and I was a grumpy, burnt out person. And my wife told me, you got to figure some stuff out. And it was the first time where I kind of realized to myself, or allowed myself to realize, there's something about this psychology thing that doesn't fit with me. That's a scary thought, right? For someone who's spent 5 years and lots of money investing their life in something. So I hadn't allowed myself to really verbalize my dissatisfaction with my profession and what I had been trained in. I actually ended up quitting a postdoc that I had at a hospital in Illinois. As a result, I called them up and said, I just need to take some time off. I'm sorry, but got to do it. I've never quit anything in my life. In fact, I'd gone straight from kindergarten. I was an child of immigrant parents. So, your job is to grow up, get a job as soon as you can. And I'd gone through school straight through kindergarten up to grad school. Took some time off. And during that time, took some time to explore. And a job opened up on the west side of Chicago at a federally qualified health center called the Lawndale Christian Health Center. And initially I was like, I don't know. I knew nothing about primary care. I didn't even think psychologists could work in primary care. So this is about 2000, 2001. And So I said, no, I'm not going to do that. But actually, two independent people in my life, unconnected, said, hey, you should really think about this job. I think this would work well for you. Um, and long story short, I took the job. I don't know why they gave me the job. I had no idea what integrated care was. That was essentially what they were trying to do. The Bureau of Primary Health Care had given them money to start in integrated care. They'd never hired a mental health professional before. This is actually one of the largest community health centers in the country. Actually, at the time, still is. And they threw me in to do this integrated care stuff. And I'm doing air quotes if you're just listening to the audio of this. And the best I can say is I just failed a lot because I kept trying to import that specialty mental health mindset that I've been trained in into primary care. I literally took out an exam room, made it into an IKEA furnished office. I set up my schedule with hour-long appointments, intakes. And my initial thought was I would be inundated with need. This is a west side of Chicago, high need, underserved area. Lots of need with also a mental health shortage area. So like naturally speaking, you'd think like, boy, he's going to be, that psychologist is going to be overwhelmed. I was actually scared. I literally was scared. I thought, man, I'm going to be overwhelmed. Like half my schedule was filled and only half of that showed up on any given day. And so out of that, you know, I think the ACT folks talk a lot about this sort of creative spot that you get into when you are in the midst of the dissonance of what your expectations and reality are, right? I entered that space, and out of that came some really creative ways to begin to explore what it might mean to actually serve in a primary care setting. So I started doing PCBH-ish things before I even knew what PCBH was. So I started hanging out with the physicians in their areas instead of my exam room. I started being willing to go into a room to see a patient of theirs when pulled in to them. This is before I even knew what a warm handoff was, all right? To see them right away, right? Like it may seem for folks these days who take it for granted what a warm handoff was. Back in that day, it felt like sacrilege to do a warm handoff because it meant I was turning my back on my profession and the hallowed intake process, right? And instead of like doing an intake, I had to go in and be helpful. I had to kind of do just amount of assessment to be helpful that day. And it started breaking down all the preconceptions about what causes change in patients' lives and how much time it takes to cause that change. You know, I can remember vividly walking into rooms within 30 seconds, have a Latino immigrant woman talk to me about childhood sexual abuse within 30 seconds of having walked down, sit down, introduce myself, and she's sharing something she hasn't shared with anybody else in her entire life. That is what changed my mind about the whole thing. First of all, I realized, why in the heck wasn't I told that these people are showing up in primary care in my training? How is it possible that this many people are accessing help here and I wasn't told about that? And I remember feeling like, you know, I can really help people because I saw what would happen even with one visit and sometimes just a couple of visits where people were really with really significant issues psychosocially and from a mental health standpoint. I felt that sense that I had a role to play here in primary care that was different than what I was trained to do, still use a lot of those same skill sets, but that energized me. And it has energized me to this day. Just that idea that we can really make a huge difference, particularly for underserved populations, which is where my heart and my main passion is, by just being accessible, by being where they are. And then the flip side of that, and I'll end the story here, at least that part of the story. the flip side was I saw how important and helpful it was to the physicians and the PAs and the NPs. I saw their demeanor change. I saw their capacity for compassion with their patients change because they had more support. They had a sense that there really was a team around them supporting the patients that they were working with. And that also energized me in a way that was really, really different. And so after that period of burnout after grad school, to feel that energy in primary care and to realize, that's when I first caught the vision. And I said, this is what we need across the country. Primary care should be redesigned along these lines, around these teams that form to help support. This is what we need. When I caught that vision, that's what resuscitated my career. I still to this day feel like if I had not fallen into that position, I don't think I'd be a psychologist today. And that's not, I'm not speaking poorly about psychologists or people who do specialty mental health. I'm just saying for me, I found meaning in that grander vision, I think, than I did with just being trained as someone who would sit with someone in an office setting for an hour a week. It just didn't fit me.
You know, Neftali, one, well done. You did it again. Super hyped right now. And there's so many different things that my mind goes to. And I think the one thing that, you know, if people watching this video, and whether you're maybe an early career professional, maybe a student or whatever it is, the thing that I love in hearing these stories, whether it be from you, whether it be from Jeff or Kirk or Patty, Sandy Blunt, you know, these people, really there's only been two people, Larry Mausch's story and then Chris Hunter's story, where there was like this intention on going into like a medical clinic. Those two had like intention. Everybody else was completely an accident. And I think that's the really cool thing for students and for early careers. Like, never underestimate what like an opportunity might inspire you in what way. And I think that's a really cool thing. And my mind also goes to, and I try not to get on these soapboxes, but I do. You know, one of the things that obviously with everything that's going on in society right now and very much appropriate conversations about race and stopping systemic racism and promoting just this culture of inclusion and humility, the thing that I always have struggled with from our field of psychology, and my mind always beats me up for saying this, and I don't know if I want to put this out on the internet, but I'm going to, you know, it's tough for us to be the field of social justice when we only see 7% of the population, when we're only reaching 7% of our community. And that's one thing that really drives me, and similar, it sounds like for you, is this idea that we get to reach our community. And what better way to promote social justice and what better way to reach and really promote what we're trying to promote about ideas and our values in psychology than to do what we're doing in primary care.
You hit the nail on the head. Absolutely. You can't really enact social justice if you're not present.
Correct.
You got to be there. You got to be at the spot where you can be helpful. And that was also a key piece of the transformation for me, because I started working at this community health center. Lawndale neighborhood historically actually is key in the history of social justice and civil rights in America. Dr. King actually resided there for a period of time, especially around the time of the riots that occurred during the civil rights movement. There were some huge riots there in Chicago, on the west side of Chicago specifically. And so by being accessible as a member of a primary care team, I realized that I had an opportunity to reach populations that wouldn't naturally come to a mental health office, either for issues of stigma or from because of insurance barriers or logistical barriers. And having that place also, frankly, I found was a more culturally appropriate place of service for those underserved populations. In this case, I'm talking primarily, it was basically half African-American, half Mexican, Latino population. And so I realized that and this hits home for me because I grew up Hispanic in New York City to working class, poor immigrant parents getting our healthcare in the emergency room at Queens General Hospital, I realized that in order to reach that community, I couldn't adequately do that in my own sort of private practice somewhere. And I think intuitively, that's part of the dissonance that I felt through the training that I had, that there was something about it that didn't match me. And it didn't match what I felt like was a meaningful way to reach underserved populations in particular. And so that really drove it. But the other piece, again, to emphasize, is this idea that a team of healers makes a whole lot more sense than individual healers. That may run somewhat counter to more of a Northern European sort of sensibility that we've sort of imported to some degree in our American culture. I would actually say that most any cultures, generally speaking, respond well to that whole idea of a sort of a community of healers. But it's certainly the case for African American, Latino populations. It was almost magical for me to realize I'm coming into these rooms, and because these people have had their bodies touched, because someone has talked to them about their physical health before my visit with them, or just as part of the context, I can come in and somehow the potency of what I do with them is increased because of that reality, that I'm not doing this myself. I've got a physician or a PA or NP who's also dealing with the other parts of their life. And then I'm coming in and talking with them about these parts of their life. And then we're blending those two together in ways that bring them together. You know, the diabetic who's having trouble eating and depressed, and right. We're bringing them together in a potent way that just makes more sense for underserved ethnic, minority, and racial groups. That was such a turn on to me. That made me feel like, you know what? Yeah, this is why I want to do, why I want to do this, and why I want to do it this way. Because the standard model, the sort of what I call the Sopranos psychotherapy model, like that only works in the movies,
right?
Literally.
Right.
Either that or you're a rich guy in Manhattan, you know?
Right. I had a student tell me the one time when we were doing interviews for our internship that he was in New York City. I forget what borough he was in, but he was in New York City doing practicum rotations. He's like, you know, in a 2 to 3 block radius, we have like, I don't know, it was an ungodly number of psychologists, like 25 to 50 psychologists. He's like, none of them took Medicaid. None of them took Medicaid. And it makes me think about this again, when we talk about like who gets psychological services. You know, a lot of times it is people that can afford it, just because of the way the insurance is structured. And then also it's like my mind is being blown right now about what you're saying about even being on a team, how much that is almost reflecting inclusion and a cultural shift, moving away. My mind just goes moving away from our individualistic kind of Western society view of this, that this is more a team, a family that's coming to that. That's beautiful. That is beautiful. And the other thing that my mind goes to, and I got to get off soapboxes, but it just, there's been so many different things going on that I get on these soapboxes. The other thing that my mind really picked up, and I want to make sure that it's making the right assumption about what you're saying. You know, we talk about burnout a lot in healthcare, and it's a real problem. It is definitely a real thing. The one thing that you said, though, it seemed like inherently in this is that, at least for you, and there's different values for other people, leaning into almost like the chaos, leaning in almost to the pace of primary care, which just intuitively, I think a lot of people say, oh, that's going to burn me out. That's going to cause me a lot more. It almost seemed like it was, I don't know if healing's the right word, but it was engaging. It was inspiring, because it allowed you to live out your values. And that's something we talk about with our trainees all the time. Like, leaning out doesn't necessarily mean less burnout. A lot of times that burns us out more. I don't know. I want to make sure, am my mind picking up on what you were saying there?
Yeah. And I know the tension that you're trying to ride there, right? So on the one hand, we don't want to diminish, we don't diminish some of the systemic issues with healthcare that need to be fixed, right? I mean, there's way too much pressure put on primary care docs to do their jobs effectively, and way too many demands on their time, on their bandwidth. They're on the screens way too much, way too many clicks, and they're held accountable in ways that don't really make sense for the outcomes that really matter to patients. So we don't want to minimize those realities. I would also say that the training of physicians needs to be revamped. I think it's crazy. I have a physician wife. I can speak to that. Yeah, it's absurd what they put these poor, caring human beings through, sort of to prepare them for, I guess, a lifetime of lashing, I guess. It's like, so there's lots of things that need to change in the system. On the other side, I totally get what you're saying as well, that primary care does has a mission. And when you do tap into that mission as a team and as an individual, that is energizing and that is protective. And things become counterintuitive, as is often the case when you lean into paradoxes. You find a whole new way of seeing the stressor. You find a whole new way of seeing the difficulty. So, for example, a tangible example is when I started that clinic, started that program at Lawndale. I literally in my interview, this is why I say I don't know how they hired me, but in my interview, I told Bruce Miller, the CEO, who's a great friend. I respect him tremendously. I thank him for hiring me. But I told him, I said, I am almost embarrassed to say this out loud. I said, I will only work with 4 to 5 families. That's it, David. Now you realize that Bruce Miller was heading up a clinic at the time, about 60,000 patient visits annually, right? But I'm going to work with 4 to 5 families. Why? Because I had this, part of what was ingrained in me early on was this, in my training, was this idea that a family-oriented approach was going to be the key and intensive work was going to be the key. In other words, I want to go deep with families and really produce real change in their lives. That's the mindset I had. So I had 4 to 5 families, and I'll do the program development on the side with the other time. That was an utter disaster from the get-go, obviously, right? But when part of that was fear. It was fear that if, like I said, I open up my schedule and I'm going to be overwhelmed and it's going to be so hard to carry the burden of seeing all these patients with really serious psychosocial and mental health and medical issues, is this fear of being overwhelmed by all that. When I switched my practice over and really started, as to use your word, lean in to what primary care was, lean into a little bit of the chaos of what it means to kind of go through a day without knowing exactly who you're going to see, when you're going to see them, how you time having to see 2 patients at the same time, all that kind of stuff. When you lean into that in a productive team-based way, so it's not just, it's not you being a hero. It's really you being part of a team, trying to do their best to care for these folks. And then you say, okay, I'm going to take 12 minutes with this patient, and then I'm going to take 20 minutes with that one, and that one's going to need 40 from me. This one, I'm just going to do a check-in for 5 minutes. You then begin to be energized, actually, by some of the chaos and the goodness that you find in that chaos of a team coming together to really do their very best to care for the patient in front of them in the situation that you have in front of you that day. And so, yes, it can feel sometimes like out of control, but I think that's kind of the lesson in a way. We need to be out of control. We need to loosen the bounds of what we do professionally, how we think of ourselves professionally, in order to find the true value that our profession brings. And our profession doesn't bring the value of a 50-minute visit.
Correct.
Our profession brings a value of a person who's specifically attuned to the human experience and what it takes to overcome the challenges that human beings experience, both on the physical, emotional, and behavioral and communal level. That's what we bring to the table. So whatever I'm going to bring in 12 minutes, I'm going to bring all of me to those 12 minutes, and I'm going to bring all of me to those 20 minutes. And yes, I get tired, I get burnt out, I get times, well, I shouldn't say I get burnt out, but I get tired
Right.
more than anything else. I get tired and exhausted. And yes, there are systemic issues sometimes in the clinics that I've worked at where just things are frustrating and flows are not quite perfect and all that kind of thing. And yes, like any community, there's strife between medical assistants and providers and, you know, some team dynamics that you have to deal with. All of that is part of the chaos too. But again, if you lean into that, you really see yourselves and say, wait a second, I have a role to play here. I can actually help this team function better. I can bring something different. And then together, we together do more than any of us individually could do. So I think that's where you ride that tension of where, yeah, things need to change to really promote healthy teams in virtually every clinic in America. And at the same time, when you're able to lean in, you actually become a better problem solver of those things that need to change.
Absolutely, absolutely. And I really just appreciate that. Again, it just gets me excited. And you're absolutely right. You know, we talk about burnout a lot with our, you know, obviously our residents, and it is just eye-opening to see what, you know, physicians go through, and really any medical provider, about their training and the expectations of these 80-hour weeks, and you know, it really is, it's inhuman. And in that, though, there's so much, especially primary care, there's so much opportunity, I think, for reinforcement. There's so much opportunity for us to feel engaged when we do lean in a lot of ways. And I like how you said that doesn't mean that you're not tired. It doesn't mean that you're not exhausted. It doesn't mean that some days weren't good days. You know, it just means that, and I like the word that you use, protective, that it can be energizing and protective. That's really cool. You know, so my mind's going, and we probably got to go long. And if you got to go, let me know whenever you got to go. Give me like a thumbs up or something like that. The thing that my mind goes to that I think would be interesting to hear your perspective. What should the outcome of integrated care be? And I think about this a lot of times, and we got some cool data, and we love showing our data from, you know, Community Health in Central Washington. We love promoting it. The one thing I often struggle with is that oftentimes, especially the patient-related outcome data, is geared to the patients that we have seen versus patients that we haven't seen. And while that's cool and that makes me feel good, like I always think, and we talk a lot about this with Jeff, is this idea of like, is that the outcome that I want? I want care to be better for everybody, not just the people that I see, right? So I'm interested in what your perspective is on this. Like, what's the outcome that people should be looking for with integrated care?
Yeah, I mean, that's a nut I've tried to crack throughout my career. The one thing I can say that the outcome is not necessarily like symptom reduction.
Okay.
Just too narrow a focus, and frankly, it places too much of an emphasis on a particular human experience. Right? So it's the idea, and this is where, again, I've been heavily influenced, as you have, by ACT, right? This idea that a symptom-free life is the best life. And for many of us who work in underserved communities, or who have worked in underserved communities, we realize that a symptom-free life would be insane.
It wouldn't be normal.
Contexts.
It would be weird.
Yeah. So why choose that as a metric?
Right.
And then the more I've lived and breathed primary care, the more I've really understood that my role in primary care, and in fact, I think probably our legacy as folks in integrated care in general and PCBH specifically, our legacy is going to be the teams and the team cultures that we leave behind. To me, that's the most transformative piece, because at every clinic I've been at, what the feedback has been that's been most impactful from administration, from fellow providers, behavioral health and medical, from front desk staff, from nurses, from medical assistants, has been this sense of gratefulness that somehow something has changed about the way the team operates by virtue of what we have done. that to me, if you think about the legacy, it's not about necessarily how many patients I saw or how many patients our team saw. It's how we changed the community of care that saw those patients. And I don't know how to capture that other than to really say, I think for me, my metrics ought to be the physician's metrics. The physician's metrics ought to be my metrics. The team's metrics ought to be our metrics. We're here to care for whole individuals. And so, yeah, that means I care as much about diabetes metrics, and I care as much about hypertension metrics as I might care about patient satisfaction and how well we're doing with getting to see patients on time and having accessibility for visits, et cetera. All of that is what I feel like is what I'm doing as a part of that team. So, yeah, less and less, I don't see the specific behavioral health metrics. And I love your numbers. Don't get me wrong. I love this stuff. And I wish more people would actually post the kind of numbers you guys are posting and the way you guys are posting it. But the mental health specific stuff only captures a really small slice of what actually integrated care is about. And I don't know how to capture the other stuff other than to say that whatever metric that primary care is judged on, or to be more specific, whatever metric that particular primary care clinic would be measured by, that's the measure I want to be measured by, because I'm pulling that same, rope along with my fellow teammates. So it doesn't really make a whole lot of sense to me to just look at, very narrow scores on a particular thing. That can be helpful for like QI processes and figuring stuff out where things are not going well in particular areas, flow processes, et cetera. But as a larger validation, honestly, like my perspective is what we're doing with PCBH is we are filling a void in the care system. Which is why almost everything you do when you compare research-wise to usual care is going to be better, But I don't use that to validate who we are in integrated care, because that's not the standard. The standard is not, can I do better than usual care?
Correct.
No, to me, it's like a duh experience. We should have had behavioral health alongside medicine the whole time.
Right.
We just didn't. And that's why we have a lot of the problems we have right now as far as how we care inefficiently for patients. So that's what we're doing. We're just fixing what should have been there the whole time.
I agree. And I think my mind goes, and I was talking to a colleague of mine, one of my mentors who's more in especially mental health world. And he was asking, what do you think the outcome measure should be and what you do? And as you said, like, I think without question, it should be the clinic specific outcomes in what we do. And I think that's a shift from really what we look at integrated behavioral health about being. I think a lot of times you say that to people like, well, why would I care about, these other scores? Like, because that's what, as you said, we should have been caring about those things all along. I do think, and I don't know how you measure it. I think you could measure it in a couple of different ways, but I think patient engagement, I think is one thing that I wish we had more data on and to see if we're helping, because one of our interns who now is a fellow, Will Summers, he had a really brilliant thing about, and he didn't come up with it, this is a term that's been around for a while, but this idea of like reverse engineering. And this idea that, what if we asked ourselves, like, how do we want patients to feel once they leave this exam room right now? And then what would we do different? And in medicine and also in psychology, right, we have really good interventions that work when people do them. We know these things will work. The problem is no one does them, or no one comes back to check in about how those things are doing. So my mind always goes to this idea of like, how do we keep people engaged? Because there's a lot of unfortunate things about our healthcare system, but the one thing that is very unfortunate, we don't focus on keeping people engaged with us. And every single time I think about what causes patients to come into a clinic, it's either when they're sick, or they have a follow-up and they're going to be told all the things that they're doing wrong and that they're not healthy. Like, why would that person be engaged? And we know the information about like treatment adherence, like are people honest and are people are genuine with things, and we know that people aren't, and that's due to what we're doing, not due to them. I just think this idea of patient engagement could be really, that again, how do you operationalize that? I don't know. But yeah.
Yeah, I think you're really right on point with that, because I think what you're pointing out is that engaging a patient really encompasses the work of the entire team, the entire
Correct.
clinic, right? From the front desk staff all the way back, right? And so that's what I'm saying. So the catalyst of behavioral health often is, not always, because there's sometimes when you can have behavioral health in a clinic, it's so isolated, so co-located that it's its own little thing. But if you're really doing really good PCBH, you are actually impacting the way registration thinks and works and acts, medical assistants, nurses, et cetera. And again, this is lived experience on my part where, those nurses who are taking the triage calls, they get better at handling the suicidal patient, the patient in crisis, the patient that's angry, right? Because of their interaction with you, because of the way in which you model that behavior, you might share some of those skills. You might even do a little bit of an in-service every once in a while. You influence their ability to understand the patient differently. And what result is that going to have? Sure, you're going to have a more engaged patient, right? You're going to have a patient who wants to come in, patient who feels respected, valued, included, patient who has providers that have some motivational interviewing training and have an understanding of like, hey, let's start with where the patient is, right? So absolutely, I think some way of measuring how engaged the patients are in their care is important. The tricky part from a research standpoint that I've always run into is that every patient population is very, very unique. And in fact, within a clinic, you'll have different populations. So there are some parts of the population that frankly don't need to be that engaged. So if you're going to measure engagement, for example, in visits, right? So you have some part of the population, they're just a healthy, low needs part of your population, and they're going to have low visits, and it doesn't look like they're very engaged, right? And then you're going to have some high needs folks. So you have to, I think we're going to have to just be better at telling the story from a data standpoint and stratify our populations more sophisticatedly in order to then match up with what exactly engagement looks like in each of those populations. Same thing I would say with physicians. I think of patient engagement. I also think of physician and medical provider engagement in general. I think it's okay for providers to actually have different sort of habits with how they interact with us as BHCs. You'll always have the high referring providers that are like referring lots of people, and you'll always have those folks that are just on the low end. You want to have some sort of floor there. That's a good floor where the clinic culture is influencing how people refer. But there's going to be variation there, in large part because of the skill of the individual. Some providers like to do a lot of their own behavioral health stuff. That's awesome. That's great. Maybe they only include us in certain kinds of situations. It all goes to the kind of a fundamental of the model that I always go back to, which is cross-pollination, right? We're trying to have overlapping sets of responsibilities as teammates. Some of our teammates are going to be better at what we do, or more better at what we do than some of their colleagues. And that's okay. It creates that variation in the data that we see. So I think the challenge is more of a data mining type challenge and a research design challenge of how do we capture that variation in a way that tells an authentic story about how we're really impacting teams. And then to your point, how patients are responding to that team culture.
Correct. Let me ask you this, because this kind of relates to it, and we'll wrap up with a couple of last questions. What do you think is the greatest threat to integrated behavioral health right now, or integrated care? Is there anything that your mind really goes to that, it does seem to be picking up steam, more and more people, it's becoming more the norm? What do you see as the greatest threat to this integrated care philosophy or this integrated care movement?
Fortunately, I don't see any big threats, but I think I do see challenges. I see the challenge of kind of maneuvering this new world of telehealth or newish world of telehealth and figuring out, because again, the world of telehealth is actually a more productive world for behavioral health to maneuver in. I've known that for years because I did some telehealth in my own past and understood, hey, this has the power of really transforming what we do. However, it really does take away some of those team factors or makes it harder to manufacture those team factors. So for example, all this stuff we've been talking about, team cultural transformation, right? The stuff that happens when I'm walking down a hallway and I bump into the physician and we laugh about a patient that we just saw. We don't laugh at the patient, but we laugh at maybe something funny one of us said or something. And then that doesn't happen. You know, the creation of culture on a team that is dispersed doesn't happen. And there's a lot of teams out there that are really dispersed right now. And there are teams that are doing a great job, like your team, of kind of maneuvering all of that and being kind of in person and kind of remote. But I think that's a challenge because I think a lot of places are going to continue on, as they should, I think, with some version of telehealth work. But they really got to pay attention to the human factor of creating, of sustaining teams. I already know that I've talked to primary care providers who are kind of getting burnt down on the whole telehealth thing. It's really hard on them. It's not as easy for them to do their work via telehealth. And it's isolating. And it's taxing in a very different way than being in clinic. So I think those are some elements. And then I think, as always, the larger movements in healthcare are what either will continue to propel or potentially stunt where we go. So the payment structure is a huge one. I think there's probably likely positive things in the future related to that. But if we were to sort of silo off behavioral health payments again and do lots of the same carve-out stuff, if we were to have more and more uninsured folks in our population, if we were to just reinforce the current fee-for-service system, all those things will stand in the way of a team-based approach of any kind, but particularly for behavioral health. Because fundamentally, the issue is this. This is the thing that nobody wants to say out loud, but it's, we cannot sustain ourselves financially. I don't care how much you work at it and try. At most clinics, it's not going to happen unless you're severely grant funded and unless you have some really special payment arrangements. And that's okay.
After this, after we get done, I'll show you some of our budget. You'll be excited. You'll be excited.
Yeah, my old clinic in Wisconsin is doing great too, but the majority of clinics are not. That's the reality. They're not doing well financially, and they're not going to do well financially because it's the numbers just don't work out in a fee-for-service system anyway. So for years, we've been beating the drumbeat of, hey, the truth is primary care doesn't make sense to be paid this way in general. We really need to be included as part of what primary care is as a standard service. And therefore, when we redesign payment for primary care, we should be including integrated care in that redesign. That's really what it comes down to. So those are the things that I think are challenges to what we do and to our system of care and to integrated care specifically. But frankly, I feel very positive about where we are and where we're going. Again, it helps to have the perspective. 2000, 2001, when I first started, there's nothing, David, there's nothing. There's one article, I think the Runyon article, the Air Force article that Tina Runyon and colleagues wrote. That was the only article I could find. I did a lit search trying to figure out what this primary care thing was, what this integrated care thing. There was nothing. No books, no literature, maybe a few articles from the 1970s about some random family medicine doc who did this experiment with a therapist in his office. That's it. And then here we are today. You look on our integrated care map. it's littered with dots all across the country. And we're probably only capturing less than 50% of what's actually happening out there on that map. But that's a huge change in just 20 years, you know? So who knows what's going to happen in 20 years? To my knowledge, to my thought thinking, I think in 20 years, it will be unconscionable for an individual to go into a primary care clinic and not be able to see a behavioral health provider. You know, I think access to psychiatry will be that much easier and fluid, both via telehealth and through, you know, collaborative care, model type care workers or care coordinators and care managers, what I'm trying to say. So it'll be the standard of care that at most clinics, you're going to have access to behavioral health support. I feel pretty confident about that.
Gets me pumped. I'll end with this. What are you excited for about CFHA in the coming year?
I'm excited about a lot of stuff. COVID notwithstanding, of course. Every conversation these days is layered with that caveat of we don't know what the future will hold and how all this is going to wrap up. But you know, I'm most proximally excited about just getting our community together. I can't tell you how energizing it is for me, and I know I get this feedback too from our members. It's just really nice to get together.
Yeah.
And I'm excited to get together, even though we have to do it virtually, which is a bummer. I was hoping to, you know, bring you guys out to your homeland of Pennsylvania, even if it is on the other side of Pennsylvania, the wrong side.
You're okay with that. We were excited about it. Yeah, we were excited on the other side. Yeah.
So I'm just excited to get together and kind of commiserate a little bit and celebrate a little bit. I think we need to celebrate. Like, we've done a really good job of working our way through this situation. I know your clinic has been a bright spot from the very beginning. You guys really adapted your protocols and worked together as a team. You know, that's what was so exciting about hearing what you guys were doing, because you could tell, like, this clinic is operating as a team. This is not just behavioral health as a siloed, separate department. They incorporated you guys from the very beginning. You guys were demonstrated your value from the very beginning, both to staff and to patients. A lot of clinics have had that experience and have bolstered their status, you know, within their clinics as a result. So I think there'll be some time to celebrate, and also a time to commiserate a little bit, because it's been a tough year. Right? It's just been really, really hard for folks. And I think particularly in primary care, you know, I really hope that getting together will be a little bit of a cathartic experience for people to rehash and to talk about what this has meant as far as changes in what they do day to day in primary care. Because it's been significant. I mean, we're sort of used to putting on our masks and washing our hands a bazillion times a day and, you know, walking awkwardly down the hallway to make sure we have the right distance with our partners. And, you know, but all those little changes have taken a little bit out of us. And so I'm looking forward to just getting together at our annual conference. And then I think beyond that, looking ahead to the coming year, I'm also really interested to see, I want to see what comes of all of this. You know, I talked about in my story, I talked about how that moment, that crisis moment, created this creative space, right? Something like that's going to happen for us in healthcare, and hopefully those of us specifically in integrated care in the coming year, where that'll bring together, I think, the transformation that we need in healthcare, the innovation that we need in healthcare to take big, bold steps like a lot of us took at the beginning of this pandemic crisis, to take that the next step, right? To really begin to say, hey, let's reach out to our payers, really do something bold with regard to payment. Let's really dig deep on our teams and figure out how to really change our team so that our struggling primary care providers do feel like this is a different experience for them to come to work. Like, not just business as usual. Like, let's redesign the way we provide care, and make primary care really live up to its vision, right? I think there's going to be some interesting things that happen as a result of all that, really good things, hopefully. And then the other piece of that too, that I think is an energizing disruptor, is our national conversation on race. I think only good things are going to come of that. More patient-centered care, more trust, hopefully, between minority populations and our clinics, more cultural humility on the part of our primarily white healthcare workforce, and more cultural competence. And out of that, maybe some interesting ideas about how to really promote health in communities, and change the way we engage patients for diabetes and hypertension and substance abuse care and all the areas where we have inequities. So it's going to be an exciting time, as ridiculously exhausting as this time is and as stressful as it is. Something good's going to come of this. I don't know exactly what that is, but I do have that sense that much like my story, where I didn't know I'd end up in primary care, who knows where we're going to end up as a healthcare system. The one thing I do know is that those of us who've been doing this kind of work, I think because we have a predisposition to change, and we have a predisposition to being open about this, my hope is that we as integrators take advantage of that we're aware of it and work with it instead of working against it. So that's always been my encouragement whenever I talk to people these days. Just take advantage of the moment. This is a moment to not just sit back, but actually say, we can make some big, bold changes right now.
And I think, it's one of the things that, I remember Bridget saying this at the beginning of COVID, BHCs, we're used to this, right? Like, we're used to this idea of, like, we got to be flexible. We got to rethink about how we're approaching patients. And I think, as you said, with these two pandemics that we're dealing with, obviously COVID, and then the systemic racism that we continue to just butt up against, and it's just becoming more of light. The one, really silver lining in this is really causing us to rethink everything. It's causing us to rethink, how do we deliver healthcare? It's causing us to rethink, what does it mean to be a healthcare system and a center, and how do we reach our patients? And I think that is neat. And BHCs, and particularly integrated BHCs, this is our bread and butter. Like, this is, we're used to change. We're used to having to, be flexible and stuff. So I think we can also help our organizations become more comfortable with that, and have our organizations see that this can be okay. Like, change isn't a bad thing. We can adapt to these things. So I just really express my appreciation, Neftali. Every single time I do consulting, every time that we do presentations, so we always end with, go to cfha.net, get involved with Collaborative Family Healthcare. And I think that has, we always were like that, but definitely since, your more kind of formal involvement in the leadership, it's been growing exponentially. So thank you for that. I know a lot of people are just pumped. So yeah, my gratitude for it. And it's nice that we have some sports back. Basketball starts tonight, LeBron plays, so I'm excited. I know you're probably excited. It's the Mets, right?
Yes, I'm a Met fan. Yeah, I'm interested to see how Bridget responds to whatever happens. It's her reactions that keep me engaged more than anything else, because I know she flies high when they're doing well, and she flies low when they're not.
We're still living on the 2016 championship. Life, no matter what happens with life, it was because of that it was made. So my gratitude, man. I really appreciate it, and I'm definitely looking forward to the conference and everything that's going to come with that. So thank you again for the leadership and giving us some time today.
No problem. My pleasure.